I actually think you're too old to be thinking even about perimenopause and menopause. Most women in their 40s will be perimenopausal.
I still get scared and I'm not quite sure why I'm feeling scared.
Women are being denied evidence-based treatment for no reason.
But how can women support themselves?
I felt really cross that I was cheated, that no one had told me before, because it is obvious.
I'm your host, Sarah Ann Macklin, and I'm on a mission to uncover the maze of health myths around nutrition and well-being and guide you through my 7 pillars of health. Join me on a journey of discovery and connection and pull up a pew for a front row seat to the most exclusive health conversations of our time. Welcome to Live Well, Be Well. One quick ask, please subscribe to this channel. The more subscribers we get, the bigger the guests will be. As women, our hormones are constantly changing. From the moment our periods start, we experience symptoms such as PMS and PMDD. But, like most women, we just sit back and deal with it. This can lead to many severe health problems being undiagnosed, and also the reason why so many women experience such severe menopausal symptoms. It's not something that I ever thought that I would need to think about now, or even how my lifestyle choices would affect this later stage in my life. And I wonder if you have. Joining me today is Dr Louise Newson, a GP, a world-leading expert in menopause, and also an author of the new book, A Definitive Guide to Perimenopause and Menopause. If, like me, you always thought this conversation should only be listened to when you're 50, then be prepared to be shocked. Welcome to Live Well, Be Well.
Oh, thank you, and thanks for inviting me.
I am so happy to have you here for a multitude of reasons, actually. So you are a British GP, but you're also a menopause specialist. And we haven't touched upon this on the show yet, but I'm going to try and touch upon it in 3 different ways. I really want to talk about menopause, I really want to talk about perimenopause, and then I also want to talk about somebody who is in their 30s, how I should be thinking about these life changes that are kind of ahead of me and before me, rather than getting to it and having a panic. So you said something on quite a few podcasts that I listened to, and it really stood out to me. And you said there's 9 months when a woman's pregnant, and they have so much amazing, by the way, attention and care during that 9 months, which you can all agree is what we hope for. But then after that stage in life, after that person's had a baby and they've moved on and they're maybe going into their perimenopause, they're kind of forgotten about. There's not as much care and attention, and I think so many women start to feel really isolated and really lost and incredibly lonely during this phase in life, because also there's a lot of shame and stigma attached to it. For a woman in her 30s, her mid-30s, I've become really increasingly aware actually of the menopause from works like yourself. And I really wanted to start, like, why is it so important that for someone like me should start thinking about this? Because I'm very much about, and so is this show, about prevention.
Absolutely, and it's great that you're bringing it up, but this is going to sound really awful. So don't
start the podcast with something awful.
I know, by insulting you. It might be a very short podcast, but I actually think you're too old to be thinking even about perimenopause and menopause, and that's for a couple of reasons. Because it really frustrates me. If you Google menopause, and I don't know if you've ever done it, it's always white, usually grey-haired women. They've usually got a fan, or they've got a glass of water, or they've got their head in their hands, usually at work. Now, you know, I'm a lot older than you, but I haven't got grey hair. I've never had a hot flush. I've never sat at work with my head in my hands. So I don't identify with those people. And there's a lot of talk about midlife with menopause. Well, for a start, I have no idea what my life expectancy is going to be. You know, neither does my 12-year-old. So actually, how do you define midlife? But then it's usually it's 40s and 50s. But then we have to be thinking about hormones rather than menopause, if you see what I mean. So I'm trying to sort of even drop the term menopause specialist and think more about a hormone specialist. But I'm not an endocrinologist. We've got hundreds, probably thousands of hormones in our body. All I'm interested in is 3 hormones. It's really basic, actually. So we can talk at length.
Let's go to the 3.
So it's estrogen, progesterone and testosterone. That's what it is. But people then say, well, they're sex hormones. They're not about sex, actually. And they're not even about gender, because men have estrogen, progesterone, testosterone. They're the forgotten hormones, really. And so when we think about the hormones, then we have to think about, well, my 12-year-old started her periods this year. She won't mind me telling everyone. But so she's got hormones in her body too. Yeah. She's going to become more aware of her hormones. So it's an awareness of the hormones from really early, because we're all different. We're all individualised. And I know it's not just about preventative medicine that you're interested in, it's about individualisation.
Totally.
And that's really crucially important. Yeah. And we respond to different things in different ways, but we also respond to these 3 hormones in different ways as well. So as soon as we understand that, that makes a huge difference, because a lot of women in their mid-30s will have had pregnancies before. Nearly all women will have had periods by the time they're in their 30s. So they'll be aware of some hormonal changes. And that's where it's really important, because if you think about what the menopause definition is, it really annoys me, and I can explain why. But if you look it up in a textbook or Google it, it's a year since the last period. So you have to wait a year before you can have this diagnosis, which, as a doctor, what do I do? Say to a woman, oh, just come back in another 3 weeks because it's been 11 months and 1 week since your last period, you're not menopausal. And it's only a day, but actually lots of women don't have periods because they have had a hysterectomy, they use a Mirena coil, increasingly people are having contraception, so they're not having, and actually I have a bit of an issue being defined by my periods as a woman. And then a lot of people say, well, it's due to fertility problems or loss of fertility is the menopause, which again, I don't find that's very helpful to be defined as, are you a fertile woman or not? It's none of anyone's business whether you're fertile or not. But also for some cultures, you don't want to be admitting you're not fertile. But also young women who have an earlier menopause can still be fertile. So that's not right either. Yeah. And so they sort of think that they can't have children, and there are some people that can even when they've had an earlier menopause. So it's just a hormonal loss, really. It's a deficiency of hormones. But before that time we have this perimenopause, and peri means around the time of, so our hormones start to decline, but they fluctuate. But it's an extension of what happens when we're younger. You know those graphs that you have where you see you have a spike of your hormones when you ovulate. So our estrogen and progesterone go quite high up, and then the second half of the cycle they drop, and by the time we have our periods they're pretty non-existent. So lots of people have that couple of days before their periods where they feel tired, they feel irritable, they might have muscle and joint aches, they might have sugar cravings. Well, they're the same. And mood.
Mine's mood.
That's exactly the same as the perimenopause and menopause. It's just called something different, but it's a hormonal change. And the sooner we realise that, the sooner then we can be clued into our body and think, well, we've got these hormonal changes. We don't have to wait until a year past our last period, or we don't have to wait till we're having real chaos in the perimenopause. We need to be aware, because then we can help people to feel better. And
can I make one thought suggestion? I'm a bit terrified to ask this, probably from my own fear. I feel like all my fears come out on the show. Just because you gave me a bit of a brainwave. So I suffer with really bad PMS. So I get it about 5 days before my period, sometimes longer, sometimes a week. And I'm really low in my mood. I have the worst stomach cramps, but I also just feel very sick and have very bad GI symptoms. And for most of my school life, I couldn't go to school when my period was due. So it's really disrupted my life, and I went on the pill, which is another thing we'll talk about, for many years, because I just didn't know what else to do. So the best thing for me was to go on the mini pill, stop my periods altogether, and then I could model, do my career, and actually just live my life. And then, becoming 30, realising I've not really had a normal menstrual cycle, for me, started to feel very unnatural, and I made the decision to come off it. So now I'm back in this kind of flux of they're everywhere. So I know that so many of my friends and my siblings have suffered with PMS. Is there a link, just from how you're describing the menstrual cycle and the menopause and perimenopause, if you're more likely to have more severe PMS symptoms when those hormones drop, because some people I know just don't have any, are you more likely to suffer when you start heading into your perimenopause?
You know the answer, don't you?
That's why I'm scared to ask the question.
Well, it's really interesting. Yes,
and why? On this show, you'll hear me talk a lot about the gut microbiome. So I'm sorry if I sound like a broken record, but it is incredibly important for so many elements of our overall health. As a woman in her 30s, I'm becoming increasingly aware of how important our gut health is for our overall hormonal health. Being a woman is never easy, But there is so much that we can do to empower our health and feel comfortable in our bodies. The health of our gut microbiome can impact our serotonin production and our sleep quality. And these are two key areas of our mental well-being. And estrogen plays a massive role in the metabolism of our sugar and insulin sensitivity, which keep your gut microbiome regulated as well as your weight. And as estrogen levels start to fluctuate, us women can be left feeling anxious, low in energy, and gaining weight with no logical explanation. But our sex hormones start to decline in our mid to late 30s, and this can cause disruption to our gut health. So investing in your gut health could be the leading preventative factor to help support you through your perimenopause and menopause symptoms. I've got something very exciting for you to try. It is the first probiotic formulated for women going through perimenopause, menopause, and beyond to help tackle the symptoms of the decline in sex hormones and to support overall health and well-being. I'm talking about the Better Gut Daily Probiotic Supplement from Better Menopause. This was developed by a nutritional therapist who was experiencing perimenopause symptoms herself. Our gut health is a central node of our well-being, and women going through this difficult stage in life sometimes need all the support and help that they can get. So if you feel that you've resonated with anything I've said, or you feel that your gut health needs that extra TLC, try the Better Gut Probiotic Supplement for 3 months to see if it helps support your digestion or any of these perimenopause or menopause symptoms that I've just spoken about. So head to bettermenopause.com and use our exclusive code BeWell to get 25% off your first order.
It's all about this sort of, people sometimes term it as reproductive depression, because it's usually the mental health issues that are worse, but obviously GI symptoms, other symptoms can occur as well. Now, some people are just more sensitive to hormones. And if you think about these graphs that I was discussing just for normal sort of regular periods, if you like, then if you think also when people are pregnant, you have very high levels of hormones, and literally overnight when the baby's born, they drop. And so people who have PMS are more likely to have postnatal depression. And then when they're perimenopausal, are far more likely to have these symptoms as well. So you're getting a flavour, lucky you, for what it was going to be like for you as an individual.
Yeah.
And it's often just, you see, every single cell in our body responds to these 3 hormones. And they're really important for biological processes that go on in our cells all the time. They're biologically active. That's why we're made with these hormones. They're important. And actually, it's very interesting because they're not just produced from our ovaries, they're also produced from our brains as well. So we've gone on and on and on for years about the period regulation, the fertility. But actually, if we have a brain injury or a stroke, one of the first things our brain does is produce progesterone and estrogen to repair our brain because they're very anti-inflammatory. It's not all coming from our ovaries. So some people will have this variation. And so that's why it's so important to know. And it's awful, actually. When I was sort of doing more menopause work, I wanted to sit in other people's clinics because you learn more about, how to actually manage patients. You can read all the papers you like, but it's not the same as practicing. So I sat in a clinic of a very well-known specialist in London. This was about 8 or 9 years ago. And one of the patients that came in was someone he'd known for a few years, and she was really young. And I thought, well, maybe she's got had an early menopause, but she had really bad PMS. She actually had PMDD, which is just the more severe premenstrual dysphoric disorder. And she was on some gel and she had some testosterone and some progesterone as well. And after she went, I said, oh, I've never done that. In general practice, we're just told to give these people antidepressants or look at their B12 or look at their other vitamins and diet. And he said, well, Louise, he said, I'm just topping up. I'm just giving back physiology. That's all I'm doing. I'm replacing what's missing. He said, often with these people, all you do is just give some hormones for those few days. So for you, the rest of your cycle, probably your hormones are fine. It's just those few days. So all we tend to do is just give hormones on those few days to top up. And it can be transformational. But the sad thing is I see a lot of women in my clinic who've got a history of that, and it's gone from 2 days to 3 days to 4 days to a week before their periods. Then they've become perimenopausal. Their cycles have changed. Their periods have become heavier or lighter or more further apart or closer together. And then I've given them hormones for their perimenopause, Then they come out and say, oh my goodness, I wish I'd done this 30 years ago. Like, why didn't anyone tell me? And it's so obvious. But sometimes in life, and certainly in medicine, it's the obvious things that go missing, because we layer on with treatments and drugs, and then we do what other people have taught us. And often in medicine, we're all so busy that you learn by your peers. You don't have time to just sit back and look at the obvious. So as soon as this professor told me, I was like, oh, I felt really cross that I was cheated, that no one had told me before, because it is obvious, but you just don't think about it.
It's interesting how you talk about it as like a hormone deficiency, and you basically just top it up, because as a nutritionist, if I see somebody who's got a B12 deficiency or an iron deficiency,
it's no different, is it?
I top them up.
Yeah.
And it's even just given, hopefully my listeners, but even just myself, that kind of personal awareness of, it's interesting how we just feel that we have to suffer.
Yes, and it's interesting because I was saying to my mother recently, who's not medical, something about PMS, because we're seeing more and more people in the clinic who've got PMS and PMDD, and the stories are harrowing. And I said to my mother, she said, yeah, but it's only a few days a month. That's what women suffer with. And I said, but mother, I said, even if it's only 3 days a month, there's 12 months a year, so that's equivalent to roughly a month a year that people are not going to school, not functioning well at work. And I'm thinking about people who play sport, they're going to be missing games, they're going to, and actually just feeling rubbish. And actually, as a doctor, one of the reasons I went into medicine was to help people feel better. So actually giving natural hormone, which is a very low dose, it's a lot lower than the contraceptive pill, to top up and people feel better. Is that wrong? Of course it's not. But also a lot of people will take the contraceptive pill for PMS, and we've got more natural types of contraceptive pill, often because they're slightly more expensive. They can't be prescribed on the NHS, but they can make quite a difference. So there are options, but if anyone's got PMS or PMDD, number one is thinking about the hormones. And it might not be estrogen, it might be progesterone or testosterone, it can be a combination, but absolutely it's really important.
Just even thinking about the menopause, because I know we're going to get onto that, and the perimenopause and everything that comes with it, and the outreach I've had on social media about this episode has completely blown my mind, just from my audience who are listening. I mean, they are so eager to learn about their hormones from you. So I really want to get onto that. And before I do, though, you mentioned a stat to me, and I've also got it written down because it's in your fantastic new book. Because I am somebody in my 30s, and also because somebody in my family went through a very early menopause, it really struck me, actually. And I think there's this odd space for somebody in their kind of mid-30s who worries about fertility and then worries about menopause, and it's a bit of a confusing age. Can you give me some stats around early menopause and what that looks like? And
so it's more common than we realise. So if you think, not saying that anyone's average, but the average age of the menopause in the UK is thought to be 51. But the perimenopause can last 10 years or so before. So by definition, most women in their 40s will be perimenopausal. But we know, and I was always taught, 1 in 100 women under the age of 40 have an early menopause. But more recent figures have said 3%. So that's about 1 in 30 women have an earlier menopause. So we call it POI, premature ovarian insufficiency. It used to be called primary ovarian failure, POF, which is horrible because there's nothing failing about these women. I know, but that's
I don't know if a woman termed that.
No, of course not. Of course not. So, but there are different causes for it. So for a lot of women, it's idiopathic, which means we haven't got a clue what's caused it, actually. Like a lot of things, they just happen. It's bad luck, really.
Yeah.
It can run in families, so it can be genetic. And so some people find if they've got female relatives who have had an earlier menopause, they more like, doesn't mean they will, but it's just that tendency, really. Some people, there are some quite unusual, quite rare genetic conditions that can cause the ovaries to fail earlier. Some people obviously have their ovaries removed, so they might have endometriosis or cysts or some other condition that means their ovaries are removed. I know it sounds really obvious, but once your ovaries are removed, you're menopausal from that day, even if you've still got your womb. So that's important. Some people have their womb removed and their ovaries preserved, but the ovaries are more likely to fail earlier. So that's important to know, that even if you've got your ovaries but you've had a hysterectomy, you might have an earlier menopause. And then there are certain treatments. So a lot of cancer treatments, for example, the chemotherapy, when it's given through the veins throughout the body, it will stop fastly dividing cells, which also happen in the ovary. So it's often temporarily cause a menopause, and also radiotherapy. So I've got quite a few patients who've had pelvic cancers, for example, cervical cancer, and they've had radiotherapy and chemotherapy. So their whole pelvic organs have either been removed or they've been damaged by radiotherapy, and that can cause an earlier menopause as well. But so many people are focusing on, especially after cancer, they think those symptoms that they're getting are side effects to the chemotherapy, and it's actually menopausal symptoms.
Well, 1 in 30 is huge.
It's huge, and there are certain groups of people where it's more common. So we've done a lot of work with women living with HIV, for example. So women living with HIV, we know are more likely to have an earlier menopause, more likely to have more severe symptoms, less likely to get treatment. Also, women who are subject to domestic abuse, both physical and sexual, are more likely to have an earlier menopause, more likely to have severe symptoms actually, and less likely to be recognised. Drug abusers, because the body, if you think any insult to our body's clever. It doesn't want us to get pregnant and add more burden. So if it's a physical stress, an emotional stress, anything else, if people have extreme weight losses, if they have an eating disorder, if they're abusing their body with drugs or alcohol, ovaries are going to switch off, and then that causes the menopause, of course. And then some drugs can, so some types of antidepressants, some types of antipsychotics can also cause a chemical menopause, if you like. But a lot of people aren't thinking that, especially if someone's, for example, subject to abuse and they're stressed and they've got low self-esteem, reduced self-worth, they're not sleeping well, they're anxious. No one's going to be asking them about their periods or could it be related to their hormones, and that person might not think about it. So you can see how it's ignored. And some studies have shown it takes 7 years for someone with an early menopause to be diagnosed, and more than 7 consultations.
Oh, wow.
Which is just awful.
But also, I think everyone's probably gone to their doctor and felt that they have a frustration, or they've left thinking they're a little bit mad because certain signs and symptoms have gone unrecognised. So for anyone, whether it's early menopause or the perimenopause, like what are the signs and symptoms to kind of look out for? Because it's interesting. You mentioned such a large amount of different lifestyle aspects, which already brings you back to the first question of prevention is so important, right?
Absolutely.
That's kind of how we started it. But say people are going to go into an early menopause, or they're in their perimenopause, they're in their mid-40s. What are the signs and symptoms that they can start to look out for?
It's so difficult because there are so many symptoms. As long as you listen, every day when I see patients, I'm learning more and more symptoms. Wow. But I've already said our hormones affect every single cell in our body. So every single organ can be affected. Some people have very few or no symptoms. Most of us do have symptoms. Some people can have horrendous symptoms. Some people have symptoms, certainly in the perimenopause, where they have certain symptoms that change within minutes, days, hours, days. So it really, really varies. But when we've looked at symptoms that we record from the Balance app, so we've had thousands of people download the free Balance app, the commonest symptoms are actually brain fog, memory problems, poor sleep, anxiety, low mood, reduced libido, headaches, muscle and joint pains. Flushes and sweats are there, but they're actually lower down than you'd imagine.
Wow, so that's the number one thing that I would think about.
Absolutely. I did it a few years ago. This is something I was doing with BBC. We put a sort of placard in the middle of Birmingham saying menopause, and we invited people to say, what do you think? What do you think it is? Everyone without fail said flushes, sweats. That's it. That's all people think, because that's all we've been taught, isn't it?
Yeah.
And that's because, I don't know if you know, when they discovered the hormones, this is the most frustrating thing. Many years ago, that when they discovered insulin, they associated with diabetes, a disease. When they discovered thyroxine, it was associated with it was Graves' disease, because it was Dr. Grave that discovered a disease. When they discovered estrogen, they just associated it with flushes and sweats. So it was associated with a symptom rather than a condition. But actually, because we know our hormones work as neurotransmitters, I've already said they're produced in the brain as well, it's no surprise that the brain effects are really, really important. And I hadn't realised until I've seen thousands of women, because these symptoms get better with hormones. So and that's what's really difficult. If I have a patient in front of me I have no idea. There's not a test. There's not a blood test. There's not a saliva or urine test to test for the menopause. So I have no idea. But often the woman does, because she says, you know what, I normally feel like that just before my periods. It's no different. And I think it's related to my hormones. And, you know, women are quite intuitive as well. They do often know. So often I'll give HRT because we know it has more benefits than risks. And then you see which symptoms improve. And it doesn't take long to work out how many of the symptoms are related. But it's difficult to know. And that's why, I mean, myself included, you don't always know. And you think, oh, am I tired because I'm having a difficult time at work? Am I stressed because my children are doing my head in? Am I because I've got a new job? Or, you know, you just, and it's really, really difficult. And that's why, you know, the question you asked me at the beginning, the sooner we are fine-tuned and think about how our hormones affect us as an individual, then we're more likely to think, actually, no, I did get symptoms like that before my periods. Maybe it is related to hormones. Let me just think. And if I think I might have PMS, when exactly? Oh, look, it's just before my periods. Or it might not be mood symptoms. It might be you're getting migraines just before, or some joint pains, or just that CBA that my children sometimes text me, can't be arsed feeling. You know, it's, or thinking through treacle, or just, you know, that sort of, and that's why the sooner we can pick it up, the sooner we can get treatment, and the less suffering we'll get. But also thinking about your prevention of disease, our hormones are really anti-inflammatory in our body. They have really important biologically active roles in our body. And we know from research from decades, the longer a woman is without her hormones, the greater the risk of diseases. So that's another, you know, when we're thinking about population health, and we're thinking about even our individuals, you know, none of us want to have diseases. It's not so much the age we live, it's the journey to that age, and keeping well is so important.
Well, it's interesting because you said to me just before the show, and I've obviously kind of looked a lot through what you do, of how much more a menopausal woman is at risk of heart disease.
Yeah.
And so when we think about actually, you know, the next stage of our life that we stay in, it's not, and like you say this a lot, so it's might sound like I'm taking words out your mouth, but it's not a transitional period. And when I heard you say that, I was like, it's so true. It's not like we just go through this transition of being pregnant and then we're not pregnant, and then our hormones kind of start to come back into our natural flow. Our hormones will be that way going forward.
And it's really interesting, and it's like, it's this light bulb moment, isn't it? And I remember years ago going to a menopause conference and being taught about all the symptoms and everything else. And there was this big debate. Do hot flushes last for 7 years or 10 years or 20 years? And which paper do you read? And it's really frustrating sometimes when you go to conferences because they're not remembering the patient. It's like, oh, it's only 7 years. 7 years, hang on a minute, someone's suffering for 7 years, like what, hang on. But then I remember going to many years ago, going to a presentation by someone called Walter Rocco, who's from the Mayo Institute, and I've had him on my podcast actually, and he's done a lot of research looking at the consequences of having your ovaries removed under the age of 40. So he'd followed people up under the age of 40, and he's got this great but really worrying graph about the incidence of diseases that occurs and how there's a sharp incline in all the inflammatory diseases, so heart disease, osteoporosis, diabetes, dementia, but also drug addiction, psychosis, bipolar, kidney disease, lung diseases. And I remember looking at this when he was lecturing and thinking, this is blowing my brain. Like, why hasn't anyone told me about this? This is absolutely awful. But then it's like, why is that happening? You know, if you've got an inquisitive mind, it's fine being told something, but you want to know why.
Yeah.
So then you go back, and I've got a pathology degree as well. So going back to basic physiology, basic pathology, thinking about the importance these hormones have in our body. So I'm not talking about HRT. This is just our natural hormones. How do they work? You think, yes, well, actually, we've got receptors in our lungs, in our brains, in our kidneys. So, of course, if we don't have them, these organs can't work as well. So whether we have symptoms or not, we've still got these inflammatory processes going on. And of course, our body is amazing. It will adapt. You know, it's like anything. If you don't have something in your body will change and adapt. But why should it? Because these are really important hormones that we have.
Completely. You're really just making me think about hormones as vitamins and minerals.
Good.
Because I talk a lot about omega-3, right? Very anti-inflammatory.
Yes, of course.
And when we don't have enough omega-3, you know, our body's super clever. It produces another fat.
Absolutely.
So it will just bring in, instead of DHA, it will start bringing in cholesterol, which is more of a structured, rigid fat. our body will adapt. And it's very similar to how I'm hearing about with the endocrine system and hormones.
And it's so interesting and very basic. So if you think all our hormones, some of your listeners might be aware of those great pathways where you think all our hormones, as in estrogen, progesterone, testosterone, are derived from cholesterol. So look, we've been grown up for years being told cholesterol's bad. And how can it be bad? It forms our cell membranes. It's really important. Of course, there are different types of cholesterol. But if you think cholesterol is the first layer before progesterone, and then from progesterone we get estrogen and testosterone. But there are different types of estrogen. There's estradiol and estrone. Estradiol's the good part, estrogen's the pro-inflammatory part. And that's where, men having progesterone, of course they have to have progesterone because the testosterone can come from that, but everything comes from cholesterol. And then you think about vitamin D as well. Is that a hormone or is that a vitamin? Well, it's both really. It's really important, but that's been neglected. And it's still a marker of low vitamin D. It can increase inflammation. So all these things work together. Our hormones don't work. For some reason, everyone's thought these hormones, estrogen, progesterone, testosterone, just work in one way. Of course they don't. They work with everything else. And that's why having the right supplements, having the right nutrition is really crucial, or our hormones won't work in the same way.
I think that's so important, because the next question I wanted to go on was HRT. And I think before we get there, there's so many important kind of common denominators that you speak about as well that are important, not just for menopause, but I guess through all of your stage of life with your hormone relationship, right? And for me, nutrition has kind of always been a very fundamental factor in that. And exercise, you speak a lot about. And I think it's really important to just touch upon that actually. Like what's your view around exercise and nutrition around this stage of life, and how should women look at it?
It's so important. And I think the most important thing is it shouldn't be seen in isolation. And I see so many women who've tried to eat the way out of the menopause and they felt failures because they've put on weight, because they just had their symptoms haven't improved. And actually, yes, there is some studies that if you don't eat chili or you reduce hot drinks, you might have less hot flushes, because of course the studies only look at hot flushes. But actually it's more than that as well. And so, yes, exercising can improve your mental health. Eating the right food can improve your mental health. Try saying to many menopausal or perimenopausal women, or maybe you, I don't know, the day before your period, right, come on, exercise, come on, eat the best food ever, come
on the sofa with chocolate and a hot water bottle.
Yeah, that's because you haven't got hormones in your body. But and that's how people feel. And so I feel really strongly that balance everything and the rest, fit into place. So balancing your hormones often can mean that people feel more motivated, more likely to think, oh, what's for supper tonight? It's less of an effort to go shopping. It's less of an effort to cook. It's easier to exercise. You haven't got the muscle joint pain, reduced stamina, so forth. So, and then when you exercise and eat better, it can help balance your hormones too. But if you haven't got the hormones, it's really difficult actually. Obviously, some women choose not to take hormones, but that's mainly because they haven't thought about them in the right way. But you can't make hormones, if you see what I mean. You can't eat them. So it's having that whole balance together. And I think the problem is, for too long we've been told HRT is so scary, we shouldn't do it, it should be the last resort. And I heard someone talking recently saying, well, of course, if you eat well and you exercise, you probably won't have any perimenopausal symptoms. Well, on personal experience, I couldn't have eaten better before I experienced symptoms, and I was doing regular exercise. Of course, anyone can always do better exercise, but I was still doing a lot and I still felt absolutely awful. So, and we're all different, but I think we can't kid ourselves that our lifestyle is going to improve. If someone had an underactive thyroid gland or someone was anemic, yes, they could make these changes, but until you replace that deficiency, it's not going to have the same effect.
So let's talk about HRT. And it's interesting that, so hormone deficiency, it's so interesting how all of this conversation coming into this was a lot about the menopause and perimenopause, but now I'm just thinking hormone deficiency in general. Because even thinking about it, for me who's not in perimenopause, I still get scared and I'm not quite sure why I'm feeling scared. And I think that's why it's so important to bring this up, because no one talks about it.
No.
And so first of all, what is HRT? Let's kind of understand what that is. And then you said something really interesting, well, there's way more benefits than risks.
Sarah, I'm so sorry to cut in, but since Live Well Be Well is all about health and well-being, I need to tell you what great mental shape I'm in today.
Since we started producing this podcast, it seems that you've been on quite a health journey. And seeing you blossom honestly fills me with joy.
My sleep cycle's on point, my gut microbiome is in better shape than ever. I'm even doing HIIT workouts, can you believe it? But the reason I rudely interrupted this interview is to tell you about the adaptogenic coffee that you've suggested to me earlier this week, which contains lion's mane mushroom and rhodiola. Two things I personally don't know much about. Perhaps you can enlighten me.
Science shows that lion's mane mushroom is known to improve memory, mental clarity, concentration, and overall just your brain health. And rhodiola is a powerful adaptogen known for its effects on stress levels and brain functioning.
Okay, that's all sounding very exciting indeed. And I can confirm these shroomy coffees are absolutely delicious. And they come in these single sachets, which is incredibly convenient. But I don't really understand what makes them so special. So what exactly is adaptogenic coffee?
The medicinal mushrooms and coffee are probably one of the most perfect pairings. You get all the benefits of regular coffee, which we do love, whilst minimizing any side effects. So why does this happen? I know you're going to ask. Caffeine is a nootropic. It increases our alertness and our attention. But many of us will have experienced the increased levels of the stress hormone cortisol, which results in, sadly, the jitters and anxiety.
This has 100% worked wonders for me this week. So where can people get them?
Okay, so if you want to try these at home, we have a special discount code from the amazing brand London Nootropics, and they have 3 different blends to choose from. So listen up, Sam. Here is your mix. You can have Zen. It's probably the most balancing. It's great if you're caffeine sensitive. Then you've got Mojo. This is perfect for that natural boost. If you're feeling a bit fatigued, it makes a really good pre-workout because of the cordyceps and also, get this, the Siberian ginseng. And my favourite, to experience the effects of lion's mane and rhodiola, get yourself some of the Flow Blend.
We've got a bit of a treat for the listeners, right? A discount code?
Yes, we do, Sam. And I know that you love it because you love a discount. So all you need to do is use the code LiveWellBeWell to get 20% off at londonnootropics.com. A box of each blend is only £15, so you're kind of getting a very good deal here. And subscription starts at £12 a month, delivered straight to your door.
It's really interesting, isn't it? Because even those 3 letters just scare people.
Yeah.
So it's always HRT and breast cancer, and I can talk about the breast cancer risk.
Yeah.
But actually even HRT, like it doesn't really say what it is, does it? Because it's saying hormone replacement therapy. Mm-hmm. Sorry, is it replacing every single hormone in my body? Of course it's not. We're just talking, actually, usually it's only about the 2, estrogen and progesterone. Because if we prescribe testosterone, we have to say HRT and testosterone. So some countries call it MHT, menopause hormonal treatment. But I don't really like that because we don't wait for the menopause to give it. So it's actually, all it is some natural hormones. So we should really say what it is, as in whether it's estrogen, progesterone or testosterone, like we call insulin or thyroxine. It's just had this term. So all it is hormones, and we replace them, but we actually, in the perimenopause, we're just topping up what's missing. So we're not replacing them as in getting rid of what's there already. So it's been made to feel really complicated, and it's not. And that's why I've spent quite a lot of time talking about what our natural hormones do. Because then me saying to you, well, those few days before your periods, you're having this hormone deficiency. Hopefully you're thinking, well, maybe I should have hormones. But you're probably not sitting there thinking, oh, maybe I'll have HRT because that sounds like scary. But natural hormones sounds fine, doesn't it? And so we're really fortunate that we do have natural hormones. So we have what we call the body identical hormones. So essentially, if you look down the microscope, they're exactly the same structure as the hormones we produce when we're younger. But other hormones, so all the contraceptives, whether they're combined contraception or the progesterone-only contraceptive, they're all synthetic. So they're similar, but they're being chemically changed. And you can imagine, I sort of say sometimes to people, it's like putting a key in a lock and the key hasn't been completely cut properly. We've all had that happen. You put it in and then you can't twist it. And that's a bit like that with some of the synthetic hormones, that they will lock onto the receptors, but they won't have this lovely, beautiful anti-inflammatory cascade of reactions that go on to help our cells to function. And so the synthetic hormones are great at switching off our ovaries, but they won't have all these lovely good biological processes. And old types of HRT were exactly the same. So many years ago when I was a junior doctor, we used to prescribe the pregnant horse's urine HRT because that's all we had. So it was derived from pregnant horse's urine, had lots of different estrogens in it. It was a tablet, and it was a tablet with a synthetic progesterone. So that, as you know, anything you put in your mouth has to be metabolized, broken down by the liver to go in the bloodstream. So breaking it down can produce all sorts of other hormones, more sort of chemical hormones, if you like. And so they had more side effects. They had more effects on the liver. They had more effects, as in there was an increased risk of clotting, increased risk of heart attack, increased risk of stroke. Small increased risk, but they were still there. But that was all we had to prescribe. So even then, the benefits were greater than the risks for most women. But now we don't prescribe those, you'll be pleased to know. We've got
Phew.
Yeah. So we've got the natural hormones, so the estradiol, which as I've already said is a good part, not the estrone. And we usually prescribe that as a patch or gel, so it goes through the skin, just into the bloodstream. So it keeps as its active form, and that can be given at different doses, different strengths. And then the progesterone is the natural progesterone, usually given orally, but it can be given as a suppository as well. And then it's the pure progesterone as well. And the same with testosterone, it's either a cream or a gel. So we can give the right dose, the right type, the right form combination to each person. Whereas before it was like a combination pill, here you go, take it and see how you go. And so the studies that everyone's scared about with the breast cancer risk,
I wanted to bring that up.
are associated with the older types of hormone. So it's like comparing, apples and pears. It's completely different. It's like but even if you unpick those, there's one study that everyone still refers to, which is incredibly frustrating because there's been so many randomized controlled studies on other medication that has just been ignored. But it just goes, people talk about it, and it's the Women's Health Initiative study, which probably should not really have been done in the first place, because it was a bit of a weird study. Because when it was started in the 1990s, we knew hormones were beneficial. We knew that they had benefits on the brain and the heart and the bones, but they wanted to see, do they have other effects when started in older women? Because they knew they had good effects starting in younger women. So the average age in this group were 63. So these women had not had HRT. They wanted women without symptoms because HRT is so effective because it's treating the underlying cause. They knew if they were women with lots of symptoms, you'd soon know who was on placebo and who was on HRT, of course. So they waited till women were older, didn't have symptoms, but a lot of those women actually had had heart attacks, heart disease, they were obese, so they were higher risk, if you like. And they were giving them the tablet type of, older type of horse's urine HRT with a synthetic progesterone. And we know they have small risks anyway. So anyway, they gave that. Then they found that there was this small increase incidence of breast cancer. Rather than analysing it properly, they just went to the media, went to the medical press. The rest is history, if you like. And HRT prescribing fell off a cliff. But when they've analysed the data properly, and now we've got 20-year data because it was so long ago, they found that this increased incidence of breast cancer wasn't even statistically significant. And actually what they found, that women who only took estrogen had a 23% lower incidence of breast cancer. So the baddie, if you like, is the synthetic progesterone that's in all the contraceptives, by the way.
And that's something that goes unmentioned.
That goes unmentioned. But actually, they also found that if women did get breast cancer on their HRT, they had a lower risk of dying from their breast cancer. And so it's really seems to be more of an association rather than a cause.
Causation.
But the other thing we have to remember when you're thinking in a bigger picture is most women worldwide die from heart disease and dementia. They don't die from breast cancer. Breast cancer is very common. 1 in 7 women develop breast cancer. So actually, we still know that HRT reduces the risk of heart disease, osteoporosis affects 1 in 2 women. So
that was one of the biggest things. When we think about
yeah.
estrogen lowering, we think about bone density,
yeah,
right?
Absolutely. And that's really important. And so the narrative has always been about breast cancer. But actually, the body identical, the natural hormones have never been shown to be associated with breast cancer risk. And even if we think, I sometimes sort of play mind games and think, well, if I was my 12-year-old, or if I was a Martian from outer space and just listened to this noise about HRT and breast cancer, when the WHI study came out and everyone stopped taking HRT, HRT prescribing was about 30% of menopausal women in the UK, and it was increasing as women were learning the benefits and feeling better. Around 1 in 12 women were getting breast cancer then. Now, HRT prescribing has more than halved, whereas the incidence of breast cancer is 1 in 7. So it's quite hard to say, breast cancer incidence has really increased, but HRT prescribing has reduced. So even if you didn't know anything about physiology or pathophysiology or risk factors for breast cancer, you would still be able to think, it can't all be related to HRT. Do you see what I mean?
So why do you think there's so much? Because everything you're telling me makes complete logical sense. Why do you think there is so much stigma around HRT or so much fear around HRT? I guess that's like the decisive question.
Yeah, I think about this a lot, and I often think, am I deluded? Am I mad? Have I read something that no one else has read, or have I not read something that people haven't? But I've come from a background of science, and I've read so many papers. But what I have also got the privilege of having a pathology degree as well, I can understand basic science. So it's quite a privilege. But I've also, for 20 years, worked, or before I started the clinic, I had this portfolio career. So I had lots of part-time jobs making up a full. So I had time to read papers. I did a lot of medical writing. Whereas if you're a busy doctor and you're seeing patients all the time, it's really difficult to get off that hamster wheel and just think, well, I'm going to spend a week reading Lancet papers and reading other academic papers and going back to basic science. And you learn by rote often, but also change is really difficult for people. So I'm coming along and saying, oh, hormones are great. Initially, people are like, what the hell is she talking about? That's not what I've learned. But if someone says to me, and things change all the time in medicine, what I prescribe for someone with raised blood pressure now is not what I did in the 1980s or 90s, when I was a very young junior doctor. But you learn and you think, why am I doing this? What am I doing? So it's this professional curiosity. But it's not just me. I'm not on a soapbox, like deluded and no one else is saying. There's lots of really good academics that we work with, lots of people who are understanding as well the basic science. And so there is a huge movement of change. Even our education programme has had over 32,000 downloads. And when I go to medical conferences, a lot of doctors are going, it's amazing, you've opened my eyes to something I'd not thought about.
And that is the beauty of science, by the way, right?
Of course it is, absolutely.
Like, it's the nuance of it. And it's the hypothesis I always remember this, is to always, the best scientists try to prove that hypothesis wrong.
Absolutely. Like, I would love, I'm quite geeky, I'm quite academic. With my research group, we often do have heated discussions about a paper we've read, and I love it. I love an academic challenge. I would love people to say, do you know what, Louise, what you're saying is completely wrong because ABC. And I'd go, great, show me those papers, let me read and let's discuss. But I always also, in medicine, because I want to sleep at night, and being a doctor, you want to do the best for your patients. I often think, well, let's look at the worst case scenario, okay? So look at the study that shows the worst incidence, and lots of those studies are observational studies. They're not randomized trials. So but if you look at the sort of people who have written studies and showing it's worst, terrible. And I went to listening to a talk recently with somebody who was saying how dangerous HRT was, and said 1 in 20 women taking HRT will get breast cancer. Now that sounds awful, but hang on a minute, I've just told you 1 in 7 women get breast cancer. Well, that's really good because that shows some protection, doesn't it? So, but even if you look at the worst studies, it's still not, you still got benefits more than risks. You've still got, benefits, even if you forget all the disease improvements. Actually, women who take HRT feel better.
I absolutely love interviews like this one, which give you so much useful advice for your own life. And if it's helped you, this is an invitation to join my inner circle. It will give you exclusive access to a host of things: expert written articles, nutritious, delicious recipes, your own Members Hub newsletter, Podcast Plus, and also products and discounts decided by me for you. For one very small investment, it will help guide and support your health. If you use the code SAMCommunity, you can get 20% off your Inner Circle membership. Just head to www.sarahannmacklin.com.
So say yes, and we're not saying you do have a high risk of breast cancer, we're actually saying that you don't. But say if that was the case, wouldn't you rather have a better quality of life than actually having a life full of pain and then getting breast cancer?
Well, this is the individual choice. So we're doing a lot of work for women who've had breast cancer, because a lot of these women are told they can't have hormones, and it's a very individualized decision. But I see women. I saw a lady last week in my clinic who'd had breast cancer 20 years ago when she was a lot younger. She'd had a menopause because of her treatment. As I've already said, chemotherapy can lead to menopause. And then her periods came back when she was in her mid-40s, and she started to feel wonderful. And the oncologist didn't mind, said, "Oh, that's great, you'll probably feel better now." And then she became 50, her period stopped, she felt dreadful. So when I saw her, she had had a few years of symptoms, she could no longer work, she was really struggling to have a relationship with her husband because she was so moody, irritable, tired. She'd put on weight, so she'd had more of this pro-inflammatory estrone in her body anyway, this not very nice estrogen. And she said, "I'm just existing, I'm not living." I'm actually worried because my mother had dementia and osteoporosis. My uncle had a heart attack when he was in his 50s. I've tried various alternatives, but I'm being denied HRT because I had breast cancer 20 years ago. But she's already had 5 years of hormones naturally after her breast cancer without any recurrence. So for her, actually, how can I say to her, no, you can't have something that may or may not increase your risk of breast cancer in the future? She knows what it's like to have had breast cancer as well. And this is where I think with medicine and science, when we're talking about helping people, it's got to be an individualized process. 1 in 7 women will get breast cancer whether they take HRT or not. So that means 1 in 7 women, and it's probably less because estrogen is so anti-inflammatory, but even if you say 1 in 7 women taking HRT will get breast cancer, it doesn't mean the HRT's caused it. But if that individual is going to worry every day and regret taking it, don't take it. It's like saying you've got a risk of having a car crash when you go in your car. If you're going to worry every time, then just just walk, don't go in the car. But I think we've not been treated as adults in this conversation. Women have just been told what they can and can't have. And I feel in medicine you can't do that.
No. Well, there's a lot of fear in it, and there's a lot of shame, and there's a lot of stigma. And I think women just feel quite lost in the conversation.
Yeah.
And so because of that, the easiest route is just to maybe not acknowledge the symptoms and the pain that they're feeling. And secondly, not to take anything. And it also kind of makes me feel a little bit that it's similar to antidepressants.
It's exactly. Well, what's even worse, it's interesting because you say don't take anything, and there was an article in the BMJ not that long ago saying all this work, especially my work, is causing over-medicalisation of the menopause, i.e. too many women are getting their hormones back. But actually, it's being medicalised already. We see a lot of women who are on antidepressants, antipsychotics, they're on blood pressure lowering treatments, they're on sleeping tablets, they're on painkillers, they're on statins to lower their cholesterol. Often when they take HRT, they don't need any of those drugs. Not great for big pharma, but I really worry, and I know you've got such good mental health knowledge, I worry about the overprescribing of antidepressants. We know that women and men who are on SSRIs have an increased incidence of osteoporosis. I've already said 1 or 2 women have osteoporosis. But actually there's increasing evidence that antidepressants can switch off our sex hormones as well. So if you're not perimenopausal before, you probably will be after. So, and we know antidepressants work better if you've got estrogen on board. So it shouldn't be, some people need antidepressants, fine, but many, many women I see and speak to have been given antidepressants instead of HRT. So where's the evidence for that,
Well, that's just the confusion of the landscape. That basically it's the narrative that's coming out the strongest in mainstream media, and that's where people feel they're being directed to. And I think that's the I think that's the anger behind all of it, the frustration actually, more than the anger. It's just more of the frustration that so many women, 51% of the population, feel lost.
Yes.
That's a huge amount.
It's awful.
Half of us.
It's horrible.
51% of us are going to feel lost. And I think that comes on really well to the amount of listener questions that I got. And I've got to make sure I get some in.
Go on then.
So I'll go with one with HRT, because you've already talked about the breast cancer one. How much does HRT affect cholesterol levels?
So when we talk about HRT here, it will be body identical hormones. So the natural hormones actually lower cholesterol because the menopause is a cardiometabolic problem. So people find that their sugar, as in their glucose levels, will increase, their blood pressure will increase, and their cholesterol, their bad cholesterol, if you like, their LDL cholesterol will increase when they don't have estrogen in their bodies.
So that's a tick. So this one came out, and it's mixed into a few different questions, because this is the number one question that came out, which is interesting because it relates to my PMS. But how can women support themselves, or what would you advise for symptoms such as anxiety, depression and insomnia? And there was a mix of questions alongside that with perimenopause and in case of intrusive thoughts, anxiety. So that seems to be, and you mentioned there about the neurotransmitters in the brain. This seems to be a huge thing.
It's massive. It's absolutely massive. And especially the anxiety can be really overwhelming for a lot of people. A lot of people do have intrusive, quite irrational thoughts. And they can often overthink and just really ruminate. And quite different to just a bit of anxiety. Everyone gets a bit, but it can be really overwhelming, and people really quite catastrophize and have quite dark thoughts sometimes as well. Now, often in medicine, like I said, you treat the underlying cause. So if people think it's related to their hormones, then often we do give hormones, but increasingly it's not just the estrogen and progesterone, testosterone as well works really well as a neurotransmitter. We've found, just our huge clinical experience, and others in other clinics have found as well, that certainly mood, anxiety, sleep can really improve with testosterone as well. So if I see a patient with me who's got all those symptoms, clearly there might be other reasons as well. But often, we rebalance the hormones to a physiological response and then see what else is left. Because far too often people have been trying lots of other things. And of course they might help a little bit, but you won't know how much is related to hormones until you've had the hormones back, because doing the testing is not going to help.
And is there any risk of when you go on these hormones? Like, is there any, obviously there is risks in everything that you take, even if you take paracetamol, but what's the kind of the risks associated with? So people go on there, what is some things that they should just be aware of that maybe then they come back to you and speak about?
Obviously all we're doing is the natural hormones. So they also, just to reassure people, they don't last in the body. People think that once you've got some gel on or a patch on, that's it. The half-life of the gel is only 18 hours. And the patch, if I took my patches off now, I can tell you tomorrow I'll have a migraine and joint pains, but it doesn't take long to work out of your system. So that's really reassuring for people to know. So the commonest side effects really are some bleeding that people can get, because the estrogen can stimulate the lining of the womb, and the womb, if it's stimulated, can cause bleeding, but that usually settles down. If people know it can settle down, that's fine, and there are things that we can do if people have bleeding. Sometimes people have breast tenderness, and you know, some people get breast tenderness throughout their cycle.
Yeah, I was going to say that's actually a symptom anyway for many women.
Well, it's a symptom related to hormones. So if we're giving hormones, it can, and that usually settles as well. But there aren't any other risks. Unfortunately, if you open the insert, and which I do of my patches, it will say risk of clot, risk of stroke, risk of heart disease, risk of everything. But actually that's not related to any evidence at all. So you just can't read it, because what they've done is they've clumped all the studies together. They've quoted from the WHI study. It's not relevant for the transdermal preparations and the natural hormones. So actually a lot of what I'm trying to think of and educate people is, what is the risk of not taking hormones, because that's what's more important. So there are risks that symptoms can continue. There are risks that there's increased bone turnover, risk of osteoporosis, increased inflammation in the body, so all those other inflammatory conditions like heart disease, diabetes, dementia can go forth, and there's a risk that other symptoms will continue and persist. So actually for 3-month trial, and we do it a lot in medicine, like if I think someone's in pain, like they've got migraine, I'll start with a first line treatment of a painkiller. if it doesn't help, then I'll try something else. Like, we're used to doing that all the time in medicine, but somehow about hormones, it's like it has to be last resort treatments. And I can't quite understand why that's happened.
Approach, isn't it?
Yeah.
It's the fearful approach.
Yes, yeah, totally.
So somebody said, why does my jaw hurt? Am I grinding my teeth? Is this another symptom? I feel like, I'm not even a menopausal doctor, but that makes me feel like that somebody's so stressed about
so it's a
what's
combination.
Going on.
So stress obviously can affect the muscles, but also our hormones are very anti-inflammatory in our muscles and joints. So they help with the synovial fluid, that nice fluid that cushions all our joints, the cartilage as well. It keeps the cartilage supple as well. So you can imagine if you haven't got those hormones, the muscles become stiffer, the joints become stiffer as well, there's less fluid. So a bit of grinding teeth that you wouldn't really notice any pain can actually be really uncomfortable. And actually, hormone levels, especially in the perimenopause, are lower at night time. So many women say to me, when they get out of bed in the morning, they feel like an old lady, everything's seized up, walking down the stairs is really uncomfortable. And then they sort of get going, and that's often because the hormones start to come back. And so that's the same with any joint as well. So there can obviously be a combination of reasons why that's happening.
God, it reminds me of the cortisol levels, where they drop in the evening
certainly.
and rise in the
but
morning.
all our hormones
This is what I mean.
fluctuate all the time, don't they? And they all work together. So if you're more stressed and you produce more cortisol and more noradrenaline and adrenaline, then your estradiol level or your estradiol requirements are going to be different as well. That's why our bodies are amazing. All these hormones work together, don't they?
You're probably listening to this show because you care about your health, both physical and mental. That's why I created Live Well, Be Well, to share new ways to think about your health. I want to talk to you quickly about something that we all experience, and that is stress. Now, we can all get stressed about a host of things, even the minor things. And stress triggers the primal response. So even simply sitting in a meeting or traffic can trigger this. This brings me on to something called the vagus nerve, and it is incredibly important within the stress response and for calming our primal brains. This device I've been using is called Sensate. Now, it's a wearable touch therapy device. Research has proven that the vagus nerve activation calms the brain medulla responsible for stress and anxiety. Sensate is a device which uses infrasound resonance, and when paired with the sessions in the Sensate companion app, it helps reduce stress and improve overall well-being. In 10 or 30-minute sessions, you can feel an incredible sense of peace, reducing all those small moments of feeling stress or anxiety throughout your day. This device is genuinely a piece of modern magic and such an exciting step in modern well-being technology. It makes the perfect gift, or even better, a self-care purchase. To experience a sense of calm at home, work, or even commuting with your busy lifestyle, just go to getsensate.com and use the code SarahAnn to get 10% off your first order.
This is another one, and I actually think this is really important, and I know there's a lot of evidence on this, but I don't see it talked about enough. Vaginal dryness.
Yes.
Causing pain and discomfort.
Yeah, it's really common.
Yeah.
So about 80% of menopausal women will have symptoms related to vaginal dryness.
That's huge.
And about 8% have treatment, which is disgusting, isn't it? I know. It's awful.
That low?
Yes. Well, some studies I've read is like 10, 11%, so you could maybe push it up to 1 in 10 women, but the minority of women are receiving treatment. And it's really important that you talk about it but it's not just vaginal dryness. So we've got hormone receptors, I've already said, everywhere, but they're in our vulva, vagina. They're also in our urinary tract as well. So in our urethra, the tube we wee out of, they're in our bladder, they're in our pelvic floor as well. So a lot of people think, oh, I'm not having sex, therefore it doesn't matter. Actually, I see a lot of women who can't sit down, they can't wear underclothes, they can't walk. You know, our vagina... Sorry to talk about the vagina.
No, so I think we should always talk about the vagina.
It's supposed to be stretchy. It's supposed to be well lubricated. We're not supposed to be aware of it, you know, other than having sex or
it's not meant to cause
whatever.
us pain.
It's not supposed to cause us pain or discomfort
it's
at all.
Cause us pleasure.
It is. It's supposed to be something pleasurable.
Meant to be.
But a lot of people think, oh, it's just part of getting older, or it might be itchy, it might be sore. They might have more discharge, so it's not always the dryness as well. But also the urinary symptoms. So a lot of people find coughing, sneezing uncomfortable. They can't hold on to urine. They're rushing to the toilet. They're getting up in the night 2 or 3 times. But they think, oh, it's all just and it's been normalised, isn't it? You can go to the chemist and buy pads. So if you cough and sneeze, it's fine. It's like making it normal. But actually, a lot of the time, that's related to low hormones in those areas, which can exacerbate all those symptoms. And it's one of the symptoms that gets worse with time. So it's not about, is it only lasting 7 years or so? It will get worse. And when we think about urinary symptoms and urinary tract infections and cystitis, most of us have had a urinary tract infection. Many of us have had recurrent urinary tract infections. But if you think about sepsis, 30% of admissions to hospital for sepsis are urosepsis, related to urinary tract infections. Most of those will be related to women, and it will be related to the hormones. And we know that one of the treatments is vaginal hormones. So we've talked about HRT, which is systemic hormones, but there's also vaginal hormones. So these come as vaginal tablet, pessary, gel, cream. There's even a ring that lasts for 3 months. So they're literally inserted in the vagina, but they don't just work in the vagina. They seep out to the surrounding tissues. So they can be transformational for urinary symptoms, urinary frequency. We've known for decades they reduce the incidence of urinary tract infections.
Wow.
So women, whether they take HRT or not, can still use vaginal hormones. And women who've had breast cancer, who may be advised not to start off using HRT, can still use vaginal hormones. So it's really like most women should probably be using vaginal hormones, but it's not just menopause. It can occur in the perimenopause, but it can also occur younger, especially with women who are on contraception.
Wow. I didn't even know about that. That's such an important
It's
area.
absolutely crucial. So lots of women who are young, who have recurrent urinary tract infections, we should be thinking about vaginal hormones. Women who are breastfeeding, that hormones level are low, they might be having some vaginal symptoms, discomfort or urinary tract symptoms. We should be thinking about vaginal hormones as well.
I'm just kind of thinking we've spoke about such a variety of things here, and amazing solutions to painful problems that so many women are experiencing. But something I definitely want to make sure that I include in this podcast, that it's not all doom and gloom.
Yes.
Because I read something in your book, and I'm so glad that you had written it, because you said, actually, it's a really empowering stage in my life. And I know that you've got a really credible story of how this has kind of become so fundamental to what you believe in. But I'd love to talk about that part of it, because I think sometimes when we can talk about all the symptoms and how we can find out the different solutions and the confusion and all of this, we kind of end up leaving it. And I've had this, not from you, but just from generally researching about the menopause and feeling quite sad for my mum that I wasn't aware she went through it. And the pain that she went through, I was obviously blindsided because I was a teenager and she didn't have any support. That you then think, gosh, God, that's coming to me soon, and I'm really fearful of it, and I'm getting anxiety thinking about it. How can we think about it in a less severe way?
I think we have to be. Empowering is really important. I think we have to be armed with knowledge, because knowledge is power, and we've had that knowledge stripped away from us for far too long, and we've been told it's something that is awful. We just have to battle through it. We just have to get on with it. I've already
Keep calm and carry on.
Yeah, absolutely, which is the worst thing
ever.
But actually, we know that there's treatment, and so we know from all the guidelines that the first line treatment for the majority of women is HRT. You wouldn't think it, because only 14% of menopausal women in the UK take HRT. Globally, it's about 5 to 6%. So there's nothing. So women are being denied evidence-based treatment for no reason. So we need to be thinking, and I'm talking about for the majority of women. So, but if we want to help as many people as possible, we need to be thinking again, why are we not taking hormones? So we've got a treatment. We can't just dangle a carrot. And it's great people are talking about the menopause. I love that the conversation is really exploding, but I also feel really sad that we're talking about it. Yes, let's just talk and have a cup of tea, and that will help me feel better. It's not going to replace my hormones. So we need to think about that.
Active.
And it's a bit coming back to like your pregnancy thing. We need to just take control and decide what's best for us. If the best thing is to take hormones because you want to reduce your risk of diseases and feel better and whatever, that's fine. If you want to take up a new exercise and ignore hormones, that's fine as well. But you need to work out, based on the evidence, what's right for you, and then enjoy that journey. Because do you know what? Being older is really hard, but also, it can be really good because you've got life experiences, you've got knowledge, you've got different groups of friends, you might have a job that you really enjoy, things might be easier. So actually, we want to just make it really positive, but it's working out everything in that sort of circle, if you like. And, you know, we've got so much great information about well-being, about nutrition, about, you know, what to do about alcohol or smoking or sleep. But actually, very few people are talking about hormones because they're so scared of them. But actually, if we've got everything right, it can make a huge difference. But it's planning it before we're in the midst of it, because it can be just too much to take on board sometimes.
It's just like the one thing that seems to stream through this podcast, which I'm so happy about, is all about the prevention and making an action plan.
Absolutely.
As opposed to being in the middle of it, in the chaos where your hormones, ironically, are everywhere and you're stressed. Trying to then figure out an action plan is much more difficult when you're in that moment than before.
Absolutely. Yeah. And it's crucially important, because we can't make the right choices when we're stressed, or in case we make short-term choices. So I'm sure others have done it. I used to do it many years ago when I ate chocolate. Oh my God, I'm so hungry. I'm just going to pick up a Mars bar, pick up a piece of chocolate. You have it, and for those 2 minutes you feel great, and then you feel awful. Like, why have I done that? Then you're filled with guilt and everything else. And that's because you hadn't planned. You didn't have some snacks or whatever, or a drink, you know, in your bag, and then you've spent money, and then you feel worse. So it's the same for the menopause. It's going to happen. We've said it might happen for many women. It is half their life. Many women, it's at least 20, 30 years. What else happens for so long? But we shouldn't see it as just a transition. We should see it as a wake-up call. Think, right, come on then. What are we going to do? How are we really going to manage it? And how I manage my menopause is going to be different to how others are, you know. But we don't need to judge others.
No.
You know, I'm blighted by migraines, so I'm completely obsessed with what I eat, drink, how I plan my food, because otherwise I'll get a migraine. But actually, in some ways, that's quite good, because I have to be really controlling. But I don't expect others to live such a rigid life as me and to not drink or whatever. But that's fine. Just do what works for you and that's right for you. But also share it with others, because it can be a really isolating journey as well.
That was my next question, and how I kind of want to bring all of this together is, you know, I am so passionate about mental health, so passionate about breaking stigmas around talking around these things. Now, I feel like a lot of women kind of get to this stage of life and maybe shut off from their partner, maybe shut off from their children if they've got a family, because they feel they've got to try and keep it together. So what kind of words of wisdom can you give to kind of anyone listening to this who has this shame or has this fear about actually opening up and being vulnerable and speaking about how they feel?
It's so important to talk. It's so hard, especially when we're talking about mental health aspects of the perimenopause, menopause, or PMS, PMDD. You know, if I had a bleeding sore on my hand and showed it to you, you would hopefully immediately say, is it painful? Do you want to plaster? If I just tell you, look, I'm absolutely exhausted and I'm really tired and I've got no self-esteem and I feel really low, you might sit there feeling really uncomfortable, thinking, oh my goodness, what am I going to say to her? Like, she's a bit, But actually, if I say, but I really want to talk, I really want to know how much I can do to help and what options are. And actually, like, even just faced with a book when you've in the midst of it, it might be too much, but actually saying to a partner, a relative, you know, do you mind just helping me a bit to muddle through, can be really helpful. And, you know, even it was my, you know, middle daughter that recognised I was so moody that she thought it was related to my hormones. So them picking up is really important as well, and being part of it. So you're not alone, because mental health is really quite scary for a lot of people. It's very isolating, and it makes people become more withdrawn and isolated. But if people know the menopause is not just about flushes, sweats, and actually the other thing that a lot of women say to me is that I can't admit that I'm on HRT because I'll be judged. My friends, my family will just say, no, what are you doing? It's almost like it's a last resort treatment. But then if you sort of know why you're taking it and feel really confident and know that you're not just taking it for your health, your immediate health, but to prevent disease as well, you'll be the one that's sort of better going forwards, if you see what I mean. But also knowing that any decision you make about any treatment is reversible. You don't have to make the decision now. You can make it in the future, or you can change your mind. And we've got some really great, nice guidance in shared decision making. And I think empowering the individual to make the choices and not having this paternalistic medicine, you must or you mustn't, or you need to or you shouldn't, then you are the patient, you are central to it. And if you don't get what you are expecting from your first consultation, you're allowed to seek help from elsewhere as well. And I think that's really important for people to know.
I was going to say, actually, people listening to this then thinking, well, maybe I've been denied HRT, or maybe I've been kind of looked at as, and you're just going through this phase and it's only going to last however long, and try X, Y, and Z. I guess what's the leaving advice for anyone who kind of does feel in that way?
They shouldn't give up, because it's not like a short-term thing that they can just ignore. Even if their symptoms don't get worse, the health risks are always there. So, talk to someone, have someone who's an advocate for you to help. And none of us as healthcare professionals mind if someone has a second opinion or a third opinion or a differing opinion. We've already said that medicine is an art and a science, and you're allowed to explore and find the right person for you. And it's often a combination of treatments that's really going to balance things properly.
I love that. It is the combination. It's never, it's very, very rarely one solution to a problem, which is really important. So my last question, Louise, to you is, what does live well, be well mean to you?
Oh, it's great, isn't it? When you say those words, live well, be well, immediately you can't say it without smiling, can you? And you did it as well when you said it, which is great. I think it's more of an internal thing, actually. It's very hard to describe, because I think it takes a while to live well and be well. We can all have a good well day, but it's about something that's sustainable, and it might take a while to get there. But once you find it, and I think it's also making sure that people know that you can live well and be well, but it doesn't have to be for 100% of the time, but trying to make it the majority is really important.
It always reminds me of that really beautiful quote, enjoy the journey and not the destination.
Absolutely, it's so important.
Because sometimes we're always trying to think about what our best lives will be at the end, and we kind of forget the whole process that it takes to get there.
And I think also remembering that the grass is not always greener, because it's so easy to look at and listen and think these people have got perfect lives, everything's wonderful. And for most of us, it's not, actually. I hate to say that.
That's one small lens.
Yeah, but it's important,
it's true.
I think.
Yeah.
So, and also, I've really learned the older I get, the more selfish I am, which I know that sounds really awful.
Which is actually not selfish, by the way.
It's not selfish, because then it means I can help more people. Yeah. So actually, to be able to obsessively think about my food, think about my sleep, my rest, my yoga practice, everything else, is really, really important. And I think making sure that you have in your sort of plan or your toolbox ways that are right for you to be able to live well and be well is so important. Yeah,
I couldn't agree more. Louise, thank you so much for coming on the show.
Thanks very much for having me.
It's been amazing, and I honestly, even people that haven't gone through the menopause or perimenopause, this is such a helpful conversation just for females in general. So thank you so much.
Thank you.